All right. Welcome back, everyone. I am delighted to present our next panel session hosted by our partners at the International AIDS Society. This session will discuss how lessons learned from the global HIV response can be applied to improve responses to current and emerging infectious diseases. For this panel session, we will have two excellent moderators. We'll have Professor Jeffrey Lazarus and Julian 𝗵𝗵𝗂𝗧𝗏. I will first introduce Professor Jeff Lazarus. So Professor Lazarus holds positions as Associate Research Professor at the Barcelona Institute for Global Health, where he leads the health systems research team, and as Associate Professor at the Faculty of Medicine, University of Barcelona, Spain. Professor Lazarus is also the Vice Chairman of the Board of the EASL International Liver Foundation. He's a member of the 𝗫𝗍 International Educational Committee and is co-chair of the HIV Outcomes Beyond Viral Suppression Coalition. Joining alongside Jeff is Julian 𝗵𝗵𝗂𝗧𝗏. Julian is an HIV and AIDS advocate who focuses on youth and key population issues in the Middle East and North Africa region. Julian has been engaged in the HIV and AIDS response since the age of 19, starting as a volunteer at local NGOs and implementing projects at the local and country level. In 2015, he joined the global network of young people living with HIV, also known as 𝗨+, and then was elected to serve as the 𝗨+ board chair. As a 𝗨+ leader, his main goal is to ensure that the voices of young people living with HIV are heard, in addition to maintaining the sustainability of the 𝗨+ network. So Jeff and Julian, thank you so much for joining today. I turn the floor over to you. Thank you.
Great, thank you very much for that introduction, Victoria. I'm really excited about this session where we're going to be focusing on HIV, and thank you to the International AIDS Society for organizing this session. We have four great speakers lined up, and this session, panel session 3, is titled Turning Threats into Opportunities, Accelerating Leadership, and Applying Lessons Learned to Strengthen the HIV Response and to Improve Responses to Current and Emerging Infectious Diseases. We have just an hour and a half. We have 4 speakers. Each speaker will speak for about 12 to 15 minutes. We'll have time for a couple of questions for clarification, and then we'll have a moderated question and answer session with the audience. So without further ado, let me turn to the first speaker. She needs very little introduction, the President of the International AIDS Society. Welcome, Adiba.
Thank you very much, Jeff, and everybody, and good evening from Kuala Lumpur. I'm going to spend the next few minutes or 10 or so minutes speaking about the need to integrate our HIV prevention and care services, particularly focusing on the vulnerable and key populations. Just a quick summary of what has happened since the beginning of the HIV epidemic 40 years ago. We now, I guess, don't need reminder that 70 million infections have occurred since the early 80s, with 35 million deaths. And last year recorded 38 million people living with HIV, with 690,000 deaths and 1.7 million new infections. Unfortunately, we were not able to meet the 2020 target, where these 1.7 million new infections represent more than 3 times the target that we had set ourselves up for. Of those who are newly infected, 62% are among key populations and their partners. Sub-Saharan Africa still bear the brunt of the majority of new infections, and we saw nearly 50% of them being among women. However, in my own region, in Southeast Asia, we are seeing a large number of deaths, even though the number of infections are not as high, but the poor access to antiretroviral treatment in Asia has led to poor outcomes in terms of mortality. So there's definitely a lot of work to be done, despite in the last 2 decades in particular, we have seen amazing advances in both treatment and prevention tools that have led to the ability to have the global goal of ending AIDS by 2030. And some of these that I want to highlight, of course, the harm reduction programs, including clean needles and syringes, and opioid maintenance treatment for people who use drugs, condoms, of course, medical male circumcision in the as prevention tools, and more recently, PrEP, that has been described as a game changer with once daily PrEP leading to up to 99% of people who take daily PrEP being prevented from becoming infected with HIV. On the treatment arm, as you know, with successful treatment can prevent up to 96% of infection. So we have all these tools over the last 4 decades that have been developed that has really been able to alter the course of HIV from being a disease that can lead to sure death to a disease that can be managed as a chronic disease. And as mentioned, an amazing amount of tools that can also effectively prevent HIV. However, as stated earlier, there are many parts of the world where these tools are not adequately implemented that has led to us not achieving the global goals of ending AIDS that we wanted to achieve. These are the 1990 targets that we set ourselves to end AIDS by 2030. Unfortunately, only 14 countries have been able to meet these targets as of last year. Despite the availability of a huge armamentarium of effective antiretroviral treatment, only 12.6 million of the 38 million people currently living with HIV, there are still 12.6 million people currently living with HIV who are not receiving treatment as they should. Despite those rather negative numbers, there are several countries, as I said earlier, 14 countries who have actually achieved those 1990 goals, 3 of which are in my region. The flag in the top right-hand corner, Cambodia and Thailand, that has of course led my region in having an effective response to HIV, are 2 of the countries that have met those targets. But as you can see in this graph, there are many who've actually shown an increase in the number of new infections in the last 4 years. As mentioned earlier, more than half of new HIV infections are among key populations and their partners. And one of the major hurdles is, of course, stigma. That's posed a major barrier to HIV services. This survey that was conducted a few years ago shows that stigma is still rife, with 61% of those people who were surveyed felt ashamed, 11% were denied health services, and 22% as a result of the stigma avoided going to local clinics. And members of the key population, such as sex workers, men who have sex with men, transgenders, and people who use drugs, and migrants, experience, as we all are familiar with, multiple layers of stigma that leads to reduced access to health services. Part of the driver to stigma is, of course, many countries still criminalize sex work, drug use, and 82 countries still criminalize some form of HIV transmission, either exposure or non-disclosure. What we have learned through decades of the HIV epidemic is an effective response require a multisectoral response, and in particular, the involvement of those affected. And as we've all heard, with the recent COVID pandemic that has led to major disruptions in HIV prevention and treatment service deliveries, the communities around the globe have responded, and in most cases, community-based services have responded by innovative ways of delivering services, including bringing HIV prevention tools and information, self-test kits to people where they're at, so that people who are at risk or who are living with HIV do not actually have to front to health facilities where you want to minimize the risk to COVID-19. The use of social media platforms have also allowed for greater dissemination of information, as well as another way of allowing those wanting to access kits and information through social media platforms. So these innovations have presented as an opportunity in times of threats from the COVID-19 pandemic, and I believe will remain and probably be enhanced and strengthened as we move forward in the next few years. These are some examples of community-based and key populations-led health services from Thailand. These were programs that were started even before the COVID pandemic, but as you can see, the key focus are on accessibility by having these services in hotspots and more flexible service hours that are suited for the lifestyle of those they intend to serve, and a one-stop service that integrates prevention as well as treatment. The other focus of these peer and community-based services ensures availability and person-centered or client-centered and are needs-based, such as for transgenders, hormone monitoring, legal consultation, and harm reduction. Another aspect is the acceptability of these services by ensuring that these services are also staffed by members of the key population themselves who truly understand their lifestyle, and to minimize the stigma and discrimination that are often experienced by members of this population. And finally, to ensure that these services are of the highest standards, staff are trained and qualified in accordance with national standards. With that, this is another example from Thailand of HIV testing and PrEP services delivered by members of the key population that saw an improvement in the scale-up of PrEP and HIV testing in Thailand through delivery of services by the MSM and transgender community. At the time of this report, 55% of Thai PrEP users receive their services through community health centers and provinces, in 6 provinces, beg your pardon. And so these kinds of community-based and peer-led services are a prime example of how integration of services that are delivered by community-based themselves community-based community partners themselves are effective in delivering services in the pre-COVID era, and certainly moving forward in this post-COVID era. The key then is to ensure that we stick to people-centered or client-centered approaches in these pandemics, and the need for these systems to be resilient, flexible, and adaptable, so that we can provide services to where they're needed through community-based, peer-led, and a whole group of services, including harm reduction, testing and counseling, and ART referrals, have been shown to be able to be effectively delivered by the communities themselves. None other than Australia, that has led the world in terms of its march towards the 1990 goals and eradicating HIV transmissions. Australia is one of those 14 countries that has been successful in reaching those 1990 targets. And from the beginning of the HIV pandemic in the 80s, Australia has embodied a true community, a true multi-sectoral response, with leadership shown in civil society, patient groups themselves, academia, clinical and political leadership, coupled with their universal health coverage and strong science and research and evidence-based approaches to their both prevention and treatment response, and needless to say, the sound financial investment that went with it. As we can see, the incidence and prevalence of HIV in Australia to date has remained low, although they have had a bit of a blurb in terms of the COVID transmission, with New South Wales and Melbourne experiencing a surge. Most other states in Australia have also, through this multi-sectoral response, seen a very effective COVID response. So with that, I'll ask in this final slide of mine is, we have shown in the last 40 years what can be done with the HIV pandemic. We've come close to attaining our goals of ending AIDS. However, as the numbers have shown, we have not met those targets. We have very effective prevention and treatment tools. What's left is for us to innovate and have stronger resolve that we can and must continue to try and avoid these unnecessary and unjust infections and deaths from this very preventable HIV disease. Thank you very much.
Thank you very much, Adiba, for this overview of the HIV pandemic. Over the last years, I've been increasingly optimistic about the world's ability to end HIV in line with the WHO and UNAIDS strategies and the Sustainable Development Goals. But what you showed at the end is that our gains are really being threatened by the COVID-19 pandemic. Now, we said to the participants that if you have questions for clarification, you can send them in, and you should do so during the talk. I don't see any right now, but if you have any questions for this presentation or further presentations, just send them on a rolling basis, even before we open up for the full question and answer discussion with all of the speakers. So I'm now going to turn to our next speaker. Nick Herbert is the co-chair of the Global TB Caucus, and he will be addressing political leadership and galvanizing attention to tuberculosis and integration with HIV. Nick, this is an issue that I've been particularly interested in, having written my PhD on it over 15 years ago at WHO, when I was surprised to find it wasn't integrated. So please tell us what the story is and what the problem is. Thanks.
Okay, well, thank you very much, Jeffrey, for that introduction. And it's a huge pleasure to be taking part in this Unite Summit today. Just to introduce myself, I was a Member of Parliament in the United Kingdom for 15 years. And I formed, in fact, and then led the TB committee in the Parliament during that time. And I'm now a member of the House of Lords, the upper house in the United Kingdom. So I continue to be a parliamentarian. And while I was in the House of Commons, I formed 6 years ago, along with fellow parliamentarians from around the world, the Global TB Caucus, which has been mentioned, which has grown now to be a parliamentary grouping of some 2,500 MPs from around the world in 150 countries, and has, I think, played a major role in making the case to drive tuberculosis up the political agenda. Partly because we saw the success of that parliamentary grouping. A year ago, I also set up the Global Equality Caucus, which launched in New York, where parliamentarians from around the world joined to take a stance to argue against discrimination against LGBT plus people. And that, of course, is highly relevant to the subject of HIV today. And it is in these roles, leading these two caucuses, that I want to speak today about the need to continue to galvanize attention to TB and, of course, HIV/AIDS, because co-infection is obviously such a big issue. So we talk about these issues now against a very different background than we might have done, say, a year ago. And the obvious change has been COVID, a massive interruption to the economies and a massive political challenge in every country in the world. And I think at the start of the COVID crisis, there was justifiably enormous concern in civil society and in the NGOs that were seeing that we were already off target in beating infectious diseases that were already out there, including HIV/AIDS, and especially off target in relation to TB, that this would further distract the world from these diseases which continue to claim millions of lives a year. But I think that it is important to try and be, as somebody has already said, optimistic, and to recognize the opportunity which growing consciousness about pandemics brings us, as well as the necessity to tackle all of these diseases, not to see ourselves as being in competition, but seeing a growing global consciousness about the issue of pandemics. It is perhaps ironic that TB was declared a global health emergency decades ago, and yet continues to claim 1.5 million lives a year. And there are some superficial similarities between TB and COVID in terms of it being an airborne infectious disease. But after that, the similarities begin to end. The thing that we experienced in relation to TB is huge difficulty in getting the world's attention, or rather perhaps the Western world's attention, to the disease, largely because it was a disease of the poor, a disease that had been around for so long that people somehow became used to it being there. Most Western politicians, most Western members of the public believed that TB had been beaten, that the advent of antibiotics meant that TB was no longer an issue. And in some respects, of course, they should have been right. But the AIDS epidemic caused a huge resurgence of TB, as we all know. And it has been a constant challenge since that time to remind world leaders that this is a disease that continued to need to be tackled. Indeed, it's been hard to persuade world leaders of the importance of taking new diseases seriously at all, as well as old diseases. AMR was an issue that had begun to rise up the political agenda, and there's obviously a very important link there with tuberculosis as the leading cause of deaths at the moment in relation to antimicrobial resistance. But still, there was a problem that TB was, if you like, the orphan disease. 2 years ago, many of us worked very hard in order to try and secure the UN high-level meeting on TB in New York to get the political attention that we needed. And a declaration was passed, and it restated the importance of meeting the Sustainable Development Goals to beat TB in what is now only 10 years' time. We will have difficulty meeting those goals in relation to the other major infectious diseases of malaria and HIV, but we are dramatically off target for meeting them in relation to TB. On the current rate of progress, we won't beat tuberculosis for 100 years, never mind in 10 years. So that declaration was sorely needed, but no sooner had it passed than the COVID crisis was upon us. And of course, there's been a massive transfer of attention and resources, quite unsurprisingly, to a disease that is affecting every country in the world, the poorest, the middle-income countries, and indeed Western countries. There's another interesting distinction between TB, HIV, AIDS, and COVID, and it's that COVID remains a disease where there is a scientific challenge, because there is, as we all know, the great quest for a vaccine and new tools to try and tackle the virus. But as we've heard, in relation to HIV/AIDS, because of the billions of dollars that have been poured into research over the course of the last few decades, we have amazing new tools that can enable us to tackle this disease. The problem with HIV/AIDS, and to a certain extent, I think this is true of TB as well, although we do need new tools for TB. We don't have a vaccine still for TB, but the problem is less a scientific one for these diseases than it is, frankly, a political one. And it was a political one before COVID. It remains a political one now. And if it is a political problem, then what it requires is political leadership to deal with it. And that is really what I want to emphasize to all my fellow parliamentarians from around the world who may be joining in to this summit over the course of the next couple of days, or listening to this session, or taking an interest in these issues. It is up to us as parliamentarians to show the leadership and to galvanize our political leaders in every country to take these issues seriously. And it should not take a new epidemic like COVID to build a consciousness about the importance of ensuring global health security. Indeed, our slogan, one of our slogans for TB used to be that TB anywhere is TB everywhere. One could use exactly the same phrase for COVID. We can't isolate these problems, in particular in relation to these kinds of highly transmissible diseases, whether airborne or otherwise, and believe that they're problems for someone else. They are problems for us all. And what the latest epidemic has reinforced is our common humanity and the importance that we all work together to tackle them. Now, this leadership is going to be absolutely vital. And the purpose of forming the Global TB Caucus and the Global Equality Caucus was to ensure that parliamentary leadership became a part of this. These can't be matters that can just rest with global and national political leaders and with civil society. Elected politicians have a role to play as well. We're the ones who pass the laws, we vote the money, we often choose the leaders or rub shoulders with the leaders, and we have influence, we have the bully pulpit, and it is our job to draw attention to the importance of tackling these issues. So let me say this in conclusion. First of all, we need to join the battle to mobilize resources. And that is in the donor countries as well as in the middle income and high burden countries. Parliamentarians have a role to mobilize resources, which will continue to be needed in the case of TB in relation to research and development, and in the case of both diseases of HIV and TB, to ensure that we have sufficient resources to implement and fight the disease. And we will come shortly to the next global fund replenishment against a much more difficult fiscal background than we've seen before. And as parliamentarians, we have a job, a really important job, to mobilize resources to ensure that the global fund can continue to do its work. Secondly, as lawmakers, we have a responsibility to ensure that we take a stand against discrimination. And that is a particular issue in relation to HIV/AIDS. As we have heard, it's also an issue in relation to TB, but a very serious one in relation to HIV/AIDS, where discrimination against gay people can seriously interrupt the effective delivery of healthcare programs. And so the work of parliamentarians in ensuring an environment that is safe, non-discriminatory, and ensuring laws protect gay people and that healthcare programs can be delivered properly, a proper human rights framework, is also our responsibility. And finally, if COVID has reminded us of anything, it is the importance of strong healthcare systems, of universal healthcare coverage. And we learned some time ago of the importance of ensuring that we don't just tackle these diseases individually, that we have strong primary healthcare systems that are equipped to ensure that we can diagnose and treat these diseases in the community, strong community healthcare systems, as we have heard. And parliamentarians also have a vital role in ensuring that those systems are developed and resourced. So that is my three-point conclusion, that we have a vital role, that part of that role is in showing leadership and in mobilizing resources, but also in tackling discrimination and making the case on an ongoing basis for universal healthcare coverage, because all of these diseases remind us that we have a common humanity, and we as parliamentarians from whatever country we are members have a duty to ensure that we can continue to take a stance against all of these diseases. Thank you.
Thank you very much. Thank you very much, Nick. Your leadership while in Parliament and now in the House of Lords and founding and leading and co-chairing the Global TB Caucus is incredibly appreciated by us citizens. I see one question that came in on Twitter. Let me just see if I can read that for us. Okay, I think it's more of a comment, so I'll bring that up in the discussion, and it was more related to Adiba's talk. So let me now hand over to my co-chair Julian to take us through the next speakers, and then to the question and answer period. Julian.
Hello everyone. Thank you, Jeff, for the introduction. Thank you for the speakers, for the organizers of the summit, and for the International AIDS Society for organizing this session. Our next speaker is Susan Bushbinder, Director of HIV Prevention Research at San Francisco Department of Public Health, Clinical Professor of Medicine, Epidemiology and Biostatistics at the University of California. Susan is going to discuss with us the threats and opportunities in pursuit of an HIV vaccine. Susan, welcome.
Opportunities in pursuit of an HIV vaccine. Now, why do we need an HIV vaccine? We have, as was described earlier, both highly effective prevention and treatment. A single pill a day can virtually eliminate new HIV infections in people who are uninfected taking this pill, the pre-exposure prophylaxis. And for people who are living with HIV, treatment, and also which comes in the form of a single pill, can lower the viral load to such an extent that there is no transmission of HIV. So when we have these effective prevention and treatment tools, isn't that enough? Well, you can see here that it's not enough. As was described earlier, we're not meeting our 2020 targets, which was to have no more than 500,000 new HIV infections a year, and we're at 1.7 million new infections a year. And as was mentioned earlier, 690,000 deaths. So another possible weapon against HIV is active immunization. And you can see on the right-hand side of this slide that active immunization is one approach. That's a traditional vaccine approach where vaccines stimulate the body to make these Y-shaped proteins called antibodies, or cells that fight off infection. And these effective vaccines can provide long-lasting HIV protection. So that's a traditional approach to providing protection against an infectious disease. We can also use passive immunization, which has also been used over decades, in which rather than having the body create these antibodies, we can infuse the antibodies directly into an individual, which then attach to HIV and prevent it from infecting cells. Now, the challenge with passive immunization is that protection lasts only up to several months. So it requires maintenance infusions, but it will also it could provide protection, and it also provides important information for us in developing HIV vaccines. If we look at the impact of vaccines just in the United States, we know, first of all, that the only way that we've eliminated an infectious disease, smallpox, was through the use of vaccines. And you can see that against all of these various infectious diseases shown in the left-hand column, and compared with the number of new infections that occurred annually before the vaccines were available, and now comparing them to 2018 cases, even where vaccine use has fallen off because of an anti-vaccine movement, you can see really tremendous improvements in the proportion of people becoming infected with these various infectious diseases. And if we look at the global impact of vaccines on early childhood deaths, you can see that in the first decade of the 21st century, an estimated 2.5 million deaths were prevented each year among children under the age of 5 through the use of just 3 of our wide variety of vaccines. That's measles, polio, and the DTP vaccines. So we're fortunate in having a very robust pipeline of HIV vaccines at all stages of HIV testing, from the earliest preclinical animal model studies all the way through antibody and vaccine efficacy studies. And these are just 4 different studies. The 𝗵𝗵𝗿𝗄 vaccine efficacy study that's taking place in 2,600 women in 5 Southern African countries that's fully enrolled and currently in follow-up. There's the 𝗫𝗍𝗄 trial, which is in 3,800 men who have sex with men and transgender persons in North and South America and in Europe. That's just beginning enrollment. And then there are 2 sister trials, both called AMP, one in sub-Saharan African women and one in men who have sex with men and transgender persons in the Americas. This is an infusion of antibodies, as was described by passive immunotherapy or passive immunoprophylaxis. And these results will be out very soon. So I'm going to describe 5 different threats and opportunities for HIV vaccines. The first threat is complacency. We can address that through remembering that HIV is still a pressing public health concern. So this is data from a survey taken in the United States in March of 2019, so a year and a half ago, in which when asked how serious of an issue do you think HIV/AIDS is today for the US, 80% said that it was either very serious or somewhat serious. So it was front of mind a year and a half ago. And when asked, how serious of a concern do you think it is for people you know, nearly half said that it was either very serious or somewhat serious for people that they knew. If we fast forward now to March of 2020, the leading concern on the part of Americans was the spread of infectious diseases, but this is undoubtedly about COVID. And so we run the risk that because COVID has taken such a prominent place in people's consciousness, that HIV/AIDS could recede from consciousness and not be seen as the kind of threat that it is. The second threat is discouragement about finding an HIV vaccine. but it gives us the opportunity to take the long view and galvanize momentum from current vaccine investments and attention. There are a number of reasons why it's difficult to make an HIV vaccine. HIV continually mutates so that every time that it replicates, it makes mistakes and doesn't correct those. And so it's constantly mutating. HIV infects the very cells in the immune system that should be fighting off infection. And once infected, HIV inserts its genetic code into your own DNA and stays there, making it impossible to clear infection from an individual who's become HIV infected. It's also unclear if the animal models that we've built to try to test whether or not a vaccine approach will work will actually predict what happens in humans. That's the reason that we need HIV vaccine research and we need clinical trials of HIV vaccines in people. We don't know how long it's going to take to develop an HIV vaccine. So if you look at the time period from the discovery of the cause of these diseases all the way to development of an HIV vaccine, there's quite a wide spectrum. We're at 37 years right now with an HIV vaccine from the time that it was first discovered in 1983 to the current time. And what we don't know is how much longer it will take before we find a safe and effective HIV vaccine. The third threat is diversion of resources. So HIV vaccine research does need adequate funding in order to be successful. And these are some data from the AIDS Vaccine Advocacy Coalition that tracks prevention dollars. These are prevention dollars overall. And what you can see is that $842 million were spent in 2018 towards HIV vaccine development, which is great, except that if you look at the trend of these green bars, you can see that actually there's been a slight decline from 2006 levels, and it's certainly level or decreasing and not increasing over time. This is where the HIV prevention research and development dollars are coming from. You can see 79% come from the public sector, 14.4% come from philanthropic efforts, and 6.6% from commercial endeavors. And you can see that the vast majority are coming from the US, but the European Union is actually also supplying a significant amount of research money towards HIV prevention research and development. But if we look specifically at the European public sector investments in HIV vaccines, you can see that in 2018, there was a pretty dramatic drop-off in the amount of funding spent, shown on the left-hand graph in green, in research and development dollars for HIV vaccines. The fourth threat is the anti-vaccine movement and vaccine hesitancy. And it reminds us that we need inclusion of diverse communities to engage in all aspects of our HIV vaccine research efforts. There is this anti-vaccine movement against all vaccines. And anti-vaccine sentiment against against COVID vaccines specifically that are currently underway. In this survey, again in the US, taken in August of this year, when people were asked if a vaccine for the coronavirus is made available to you, will you choose to be vaccinated or not? And overall, 60% of adults said yes, they would, but 35% said that they wouldn't, and the other remaining proportion were undecided. But you can see that there's these racial and ethnic disparities where Black and Latinx communities in the United States were less likely to say that they would receive a coronavirus vaccine. And that's really problematic given the disproportionate impact that coronavirus has had on Black and Latinx communities, similar to the disproportionate impact that HIV/AIDS has had in those communities. And so it's also a concern for HIV vaccine research. The fifth threat is waning political will. And it reminds us that HIV vaccine research needs multi-sector support, including from political and policy leaders. I want to give you as an example the work that we're doing in San Francisco on getting to zero, which is having zero new HIV infections, zero HIV deaths, and zero HIV stigma and discrimination to become the first municipal jurisdiction in the United States to achieve the UNAIDS vision of getting to zero. What we've done is we've built on a framework of collective impact. We've created a freestanding organization that includes city government, the HIV Planning Council, community-based organizations, people from various components of the private sector, research institutions, and advocates and other organizing groups. And under this framework of collective impact, rather than having isolated impact, we align everyone's agendas towards these common goals using common metrics. And by doing that, since the onset of our Getting to Zero efforts, we've seen this 58% decline in new HIV diagnoses in San Francisco, and that's compared with the national average, which has been completely flat with no decline in new diagnoses nationally. So we know that we can ignite world leadership behind a call for vaccines because it's been done for a COVID vaccine with over 140 world leaders signing on to this effort to develop a COVID vaccine. And we have to remember that we're in a better position to approach COVID-19 vaccine development because of all of the tremendous innovation and investment that's gone into HIV vaccine development. In fact, if you look at the leading platforms for COVID vaccines, they're really built on the shoulders of the HIV vaccine effort, where there have been HIV vaccine efforts in all of these various platforms for developing an HIV vaccine. And if we leverage the HIV vaccine enterprise for COVID vaccine research, you can see that we've done immune system research that tells us how RNA vaccines work and help us to analyze RNA vaccines at a molecular level. Vaccine administration and vaccine platforms have all been mobilized to be used in the COVID vaccine effort, as have research and funding collaborations, the clinical research capacity. Most of the COVID vaccines currently under testing right now are being built on the HIV vaccine research infrastructure and are being tested in those sites. And the community engagement efforts that are underway to mobilize individual and community level interest in COVID vaccines has been built on the principles of good participatory practice, which was built for HIV vaccine research. So in conclusion, HIV remains a substantial global threat, and an HIV vaccine is needed to control the epidemic. HIV disproportionately affects our most vulnerable populations. Despite challenges, HIV vaccine research is making progress. HIV vaccine research has jump-started the COVID vaccine effort, and the tremendous attention now paid to COVID vaccines should be harnessed to mobilize support and funding for HIV vaccine development. Because an HIV vaccine research is going to require multi-sector support to achieve the goal of developing a safe and effective HIV vaccine. And so our asks are to show leadership by supporting investment in research and development in HIV vaccines, to facilitate sharing knowledge between academia, industry, and across public health, so that we can ensure that the best minds are scrutinizing and contributing thought leadership to improving pandemic response and preparedness. Thank you so much.
Thank you, Susan, for the presentation and for the great work that you have been doing, for showing how really important it is today to get a vaccine that's for people, whether it is HIV or COVID-19. Our next speaker would be 𝗪𝗠𝗃𝗧𝗃, pediatric lead for HIV, hepatitis, and STI department at WHO. I will be talking about Mind the Gap, accelerating access to treatment and meeting the needs of diverse children and adolescents. Welcome, Martina.
Thank you very much, Julian, and thanks a lot on behalf of WHO to the organizers for the opportunity to contribute to this important summit. And a special thank also to IAS for the chance to zoom in this important gap which relates to the well-being of children and adolescents living with HIV. Because if it's true that we have made tremendous progress over the last 10 years in preventing vertical transmission and reducing the number of new infections, it's also true that we're not done yet. And that's a consistent message that we are seeing from some of the reports that were launched earlier this year, which are really showing how children continue to lag behind the progress that we are making in adults. Today, we can expect up to 400 children acquiring HIV infections and more than 260 dying because of AIDS-related condition. So I really think that we have to step back and ask ourselves a really important question. Why do we accept the status quo? Why do we accept that 40% of the infants that are exposed to HIV don't receive virological testing in their first 2 months of life, when we know that disease progression is really fast and mortality disproportionately affect this group of younger children? Why do we accept that only half of the 1.8 million children living with HIV do not receive life-saving antiretroviral therapy? And even if they do so, that only 1 in 3 reaches virological suppression and control of the virus. Now, we know that, unfortunately, we are unlikely to make tremendous progress this year because of the COVID-19 pandemic, which is really exposing our weaknesses and potentially reverting a lot of the progress that we've made over the past years. What we are seeing is the reduction of uptake of facility-based services that are typically provided to mothers and children. This is because of the public health measures, or because mothers and children struggle to find transport to get to the facility, or because they're scared and don't know enough about COVID-19. As a result, we're seeing mothers and children not being tested or receiving antiretroviral therapy. And on top of that, we continue to have reports about ARV stockout for pediatric formulations at the time when actually a lot of countries were making an important shift towards more optimal regimen for children. Now, unfortunately, we don't really know how this is all going to play out for pediatric HIV and what the actual impact of COVID-19 will be on the pediatric HIV epidemic. But there's a number of colleagues that have explored this issue through mathematical modeling. And from this work, for example, you can see how we can expect up to 86% increase in the number of new pediatric infections, technically taking us back to where we were in 2014. Now, we know that the implication, the consequences of these services disruption is not going to end once the epidemic is under control, because we can see that some of the excess mortality that we can expect may continue over time. And what we have to do is really to get ready to be able to prevent this excess mortality and to be able to address the additional needs that this population will present in the next future. So it's very clear to me that we can't really sit and wait for an AIDS-free generation to come. We really need to act now, because these children don't really have time to lose. And we need to do so by going back to the basics and really to implement better and more widely those things that we know that work. For example, testing the children of individuals living with HIV. Family-based testing is really a key intervention that is cheap and is easy to do, but we're not doing enough. And we know that it has a lot of potential to really be able to identify those kids that we don't have in the system yet. We also need to be better at more rapidly diagnose HIV in infants who are affected by disproportionate mortality, as I mentioned earlier. And this is through the introduction of new tools that we now have available, such as the point-of-care early infant diagnosis technologies that actually have been quite widely implemented, but their use is still limited. And so it's really important that we really emphasize the importance of using these tools and really scale them up more broadly. We also need to use the new formulation that we now have available. We've struggled so much with this issue over time, and we didn't have the right drugs that we wanted to treat children living with HIV. And now we have better tools, better drugs, and better formulation that can be taken to scale much more quickly than we've done before. But it's not just about the virus. It's also about placing a long-term vision to the health of these children and adolescents living with HIV. Because we know that what we have to do is really make sure that they reach their full potential. And that is through making sure that we screen some of the neurodevelopmental delays, for example, other comorbidities, as well as some of the challenges with nutrition, with disabilities that are becoming more frequent, and certainly mental health issues that have been reported increasingly in adolescents who live their entire life with HIV. So it's very clear that we need to tackle this broader and more holistic approach to the life and well-being of children living with HIV, and we have to do that in a comprehensive manner. As we do all of this work, of course, we also need to learn from our own experience and be able to document what we're doing in the country, but also to build on well-conducted operational research that needs to be well-funded and well-coordinated, because we need that research to be able to well design our programs and be able to mix the interventions that we know that work for the highest impact and take them to scale according to the epidemic context that we are considering. We also need to be able to explore innovations and new ways of delivering services to our patients. And often that it's possible when we're actually under pressure, and identify new ways of delivering services to children and adolescents becomes a necessity. And this is where I see COVID-19 as a key opportunity for us to do a bit of that. For example, we've seen many countries adopting and implementing multi-month dispensing for children and adolescents, something that has been recommended by WHO for a number of years now, but hasn't been implemented for children and adolescents as much. And so we really hope that these changes that are happening right now during the COVID-19 pandemic will continue and survive beyond COVID-19. We also seen that digital tools can be powerful and can be an important way of providing support, particularly to adolescents, sharing information and ensuring that support is provided to them in order to better adhere to treatment, which we know is a challenging issue for them. Now, we know that digital tools don't necessarily reach everyone in need, but I think they really illustrate that through this pandemic, we are discovering additional ways of delivering services to our patients, and we should really build on the experience we are generating right now to be able to take it to the future and improve the way we combine and deliver services to our children. Of course, as we do this, we shouldn't lose the sight of innovation and really how we can improve the future of children and adolescents by developing new tools to diagnose HIV or to treat HIV. And I think that COVID-19 again presents us a great opportunity to be inspired on how to do things differently. I think that over the last 8 months, we've witnessed an unprecedented level of collaboration. So many governments have come together to really support politically the response to COVID-19 pandemic, have mobilized resources and forged partnership to really push this agenda forward. We've also seen the research community trying different ways of to address the research questions that we had, and some competitors coming together for a common goal. And even within that, we've seen some improvement for children. For example, we've seen the 𝗪𝗫𝗫𝗫 pediatric investigation plan being designed and approved very rapidly and much more quickly than ever before. So I really hope that COVID-19 and the work that we are doing in R&D for COVID-19 can inspire us to do things differently and to really apply some of this to pediatric HIV that right now has a much higher mortality than COVID-19, the pediatric population, at least based on what we know so far. We want to use this new way of approaching things to design new tools to, for example, more cheaply and easily diagnose HIV in children, but also to make sure that if there are new therapeutics that are available for adults, they don't take 10 years before they actually get to the hands of children. We know that all this work requires partnership, leadership, and really a good coordinated approach. And this is very much what we have as principles behind what we call the Global Accelerator for Pediatric Formulations, GAPF, which is a WHO network which was recently set up in collaboration with our funding members, which are 𝗪𝗪, 𝗪𝗪, MPP, and PENTA. In collaboration with these partners, we're really trying to ensure that some of the key barriers that are there to develop better medicine to children are addressed. And that's not just for HIV, it's for many infectious diseases and even beyond that. We know that what we need is to join forces, connect the dots, and be able to evaluate more adequately some of these medicine for children, and that we need to develop the formulation more quickly and introduce them and take them to scale more quickly and safely. We know that this is not going to happen overnight, and we know that this is going to take the effort and the contribution of several stakeholders on the ground. So it's very clear to me that no one can do this alone, and we all need to have a role into this. So it's very clear that we all have a role to play, and I think that you today can certainly do something more. You can, for example, raise the attention to children and adolescents and ensure they're captured in your national guidelines and national strategic plans so that they're not forgotten and they're right there front and center in what will be happening in the next few months in the HIV response. You also can adopt policy to enable rapid access and rollout of new tools, such as the one that I mentioned, that will help us to diagnose and treat better HIV in children and adolescents. And you can ensure that as programs are being implemented, data is generated, it's collected, and experience is shared, because that's going to be critical for us to ensure that we learn from our own experience and can adjust and adapt over time the mix of intervention that we want to deliver for the highest impact according to the epidemic context. And finally, but very importantly, a strong partnership with the community is of essence to ensure that we create the demand for services, but also that we design these services in a way that is better suited to the individuals that we are targeting with a true people-centered approach. So I really call on you and on all of us today to make sure that we don't let COVID-19 stop our progress. We can do this together, and we certainly should not give up now. Our children and our adolescents living with HIV do need us, and they need your support, they need your leadership, and they need your collaboration. So I really call on us to ensure that we continue this work and we actually get ready to build back better, as we say, after the COVID-19 pandemic, and make sure that children are not left behind. So I'll stop there and thank really colleagues in IAS, and in particular within the CIPHER program that has contributed so much to this area of work, and all of you for your attention. Thank you.
Thank you, Martina, for the presentation and for always pushing for adolescent health and HIV. We would like now to open the floor for questions and answers for our panelists. I would like to start by asking a question for Adhiba, the president of the International AIDS Society. Adhiba, you have talked about the 1990 targets and the countries, 14 countries that have reached those targets, including Cambodia and Thailand. What we would like to hear from you is regarding those targets, and through what we're hearing about the disruption of services in several countries due to COVID-19, do you think those targets will be maintained in the next upcoming future years? And how do you feel about, will those countries still maintain reaching those targets, or they will not be able to keep them?
Yeah, that's the global concern, isn't it, Julian? Whether the gains that we've made in the last few years are going to be maintained. The concern that everybody has, and Susan has very eloquently outlined, it's the disruption. It's not just in the disruption in services, but the shifting of resources that are much needed. Many of these countries that you saw that have reached the 1990 goals are also countries that are very dependent on international funding, and I think many countries are feeling very nervous that some of this funding may either be shifted towards a COVID response, or because of the general global economic the negative situation globally, that what once was relatively generous support may not be there. So I think we will need to see what happens in the next few months ahead of us, but we certainly need to be prepared and to keep HIV and other infectious diseases, up front and central, so that it doesn't get forgotten.
Thank you.
So I see a question that just came in to Nick Herbert. It says that Stop TB modeling suggests that COVID-19 will put the TB response back 5 to 8 years, what are some steps the Global TB Caucus and the TB community, and I would add including parliamentarians, can take to mitigate this harm?
Well, that's right. And it is a huge concern. I mean, as I mentioned, we were already substantially off track as it was. And this impact was the very last thing we needed in terms of taking steps to try and beat this disease. So what can we do about it? Well, I think it all comes down to accountability and holding political leaders and governments accountable for the pledges that they made through the SDGs, through the high-level meeting, to implement programs and to provide the funding that will enable TB to be beaten. And parliamentarians have a very important role to play in that accountability, in using their voice and their vote to continue to raise the importance of these issues. And we must work closely with civil society in maintaining that pressure. So we must draw attention to the problems in a way that doesn't suggest that we are belittling or trying to take attention away from COVID. Everybody understands why there is so much focus and concern about COVID, but it is perfectly proper for us to draw attention to the situation with diseases that were already having a very significant human toll. And TB is the world's deadliest infectious disease in terms of the numbers of people that it is killing each year, and will continue to do so unless we raise our voices. It's perfectly proper to say that, just as we have heard from, for instance, those who are involved in the treatment of cancer, who have in Western countries and doubtless elsewhere been raising considerable concerns about the impact on cancer programs of COVID, because for different reasons, that not because there's been a transfer of resources, but because people haven't been presenting themselves for diagnosis and treatment. Unless we are willing to draw attention to these problems and to speak out about them, then we can't expect that they will just improve on their own. Now, there is a specific opportunity in relation to TB, which is that we do have the 2-year anniversary of the high-level meeting. We need to review progress in relation to the declaration. Unsurprisingly, we're not going to have met the targets that were set in that declaration, and we continue, therefore, to be significantly off track in relation to the SDG targets. We need to reveal that. We need to say what more needs to be done, and we then need to make it specific to each country to demonstrate to them what does need to be done. We need to explain to them why it's important in humanitarian terms and why this is not an alternative to dealing with COVID, but is deeply linked to it, because it's about strengthening health systems, ensuring resilience, and ensuring global health security. So getting the information, showing how we're off track, and holding governments to account, that's what we need to be doing, and we need to ensure that parliamentarians play their role in that.
Thank you very much. The 2-year anniversary of the high-level meeting will be an excellent opportunity. I'm wondering, I mean, since TB and COVID-19 are both respiratory infections diseases, I mean, have you seen already around the world any natural collaborations forming where TB organizations have been successful in getting a focus on TB, given that it's a particularly dangerous comorbidity if there's COVID-19
I can't really answer that.
as
I think
well?
it'd be very interesting to see. I think that, not surprisingly, there was a great concern at the beginning of the COVID crisis that there was going to be a big impact on TB programs, and certainly we know that there was already insufficient R&D in relation to TB as it was, and there has been quite a transfer of resources in relation to R&D towards the fight to discover a COVID vaccine. So we need to I think, monitor all of this very carefully. I think you're right to try and present it in terms of an opportunity as well as a threat. You know, the opportunity are that both are respiratory diseases. The opportunity is that both do require effective surveillance, strong diagnostic capability, and healthcare systems in order to ensure the delivery of the healthcare in the case of infection. And we need to try and build collaboration on that basis.
Great, thank you very much. Martina, thank you so much for drawing attention to children and young people. They were a little bit out of focus at the beginning of the COVID-19 pandemic with so many elderly disproportionately affected. Now we're seeing lots of discussions around young people, possibly, you know, often asymptomatic and transmission issues. When I was at WHO, you know, over a decade ago in the HIV department, we used to say, you know, treat the person and not the virus. That later morphed into the WHO people-centered health systems approach that we're all familiar with. And so my question really to all of the panelists is, you know, with the challenge of COVID-19, how do we keep a focus on HIV, on people already diagnosed, people living with HIV, and not just the viruses, but also issues related at the cornerstone of people-centered health systems, so quality of life, and particularly health-related quality of life. I mean, I feel like we're in such a rush now to address this virus and that you know, bacterial infection. How do we get the discussion back to the people? And you alluded to this, or you mentioned it in your presentation when you started talking about children and the opportunity to address nutrition and other issues. But how do we really hammer this down, and what's the role of parliamentarians?
Thank you very much, Jeff. That's a really good point and a great question. I think that from the WHO standpoint, we really see the universal health coverage as our key framework within which we expand the focus of our work beyond the virus, as you said. And I think in doing so, clearly COVID-19 right now is a major threat to universal health coverage, directly or indirectly. And I think that if we keep a focus on that, we can, you know, at least continue to make progress in the HIV response. I think by doing a number of things. For example, as you said, just considering the broader health system, and by ensuring that maybe as we move forward in the next few months, as people come back to the facility, we really have an integrated approach to health, so that yes, we provide HIV services, but we provide those other essential services that people may have missed during the public health measures. And so that we have even more than before an integrated approach to health. Certainly for maternal child health, that's particularly important because a lot of these interventions are delivered in an integrated manner, but we need to do more of that and make sure that we don't miss an opportunity to really catch up in a way with what we've missed and we might have missed over the last few months. I think that, again, in maternal child health, we are used to think about the long term. We are used to think about, you know, that full potential that we want children and adolescents to reach. And I think that really needs to be our long-term goal. And yes, COVID-19 is a major threat to some of the work we've done already and we are doing, but we need to really think ahead of that. And I think that, again, universal health coverage is going to be a critical framework within which we can work together.
Great, I think I'll unmute myself and say thank you. So I'm not just talking to myself. Thank you for that answer. So Julian, I see a question that just came in to Susan. Are you seeing that as well?
Yes, definitely. So there's the question which came in to Susan. Susan, you have showed us the data about acceptance of COVID-19 vaccines in a panel that's discussing the HIV response. What would be the response of the population to an HIV vaccine?
I think you're on mute, Susan. It's a good club to be in.
There we go. Okay, we'll try again. It's an excellent question, and there is real concern about whether or not people are going to want to get an HIV vaccine. There's both this anti-vaccine movement that's more global, that doesn't just affect people in the United States, obviously, but we hear about it in Europe, in South America, and around the world. And then there's the additional concern that people may not want to get an HIV vaccine because it may be connected to stigma, that people might see it as, oh, I'm being recognized as someone at risk of HIV, therefore I fall into a category that says something negative about me. And so we really need to work to fight against HIV-related stigma, but also to work on having people understand the process by which vaccines are developed, and that there are real advantages to vaccine-based immunity as opposed to natural-based immunity. Vaccine-based immunity is intended to prevent disease from occurring. And it's the only way, as I said before, that we've eliminated an infectious disease. And it's really a critical way that we've controlled both early childhood death, as well as a lot of morbidity on the part of both children and adults. And so we do need to work against this anti-vaccine movement and towards acceptability of vaccines. And it's going to be quite an uphill battle. And so one of the things that we're trying to do is to encourage participation in our vaccine research from all walks of life and from people who are both affected by HIV in their communities, but also to make sure that we've got the broad diversity of individuals who are affected by HIV, and particular communities of color, to get them involved in all aspects of HIV research, HIV vaccine research, including in conducting the research and being the investigators who are leading the research, and in participating in the vaccine research effort. Because we need to show that these vaccines are both safe and effective in populations most at risk of HIV. This anti-vaccine movement is really a challenging one for us to address, and we need to do everything that we can to explain the safety that goes into development of vaccines, all of the safeguards that are put into place to protect the safety and well-being of people participating in research, and ultimately to getting these HIV vaccines once we have one that's available and effective.
Great, thank you very much. Now, we are joined by many parliamentarians in the audience, and I know, not as well as Nick and others, but that parliamentarians are very busy. They need specific messages. So if each member of the panel could tell us one major threat from your point of view and one opportunity in terms of the COVID-19 pandemic and our focus on HIV that you would want to pass on to parliamentarians, either parliamentarians globally or in your country or in your particular region. So a major threat and a major opportunity that you would want to make sure that they remember from this session.
Who's going first, Jeffrey? Am I?
Whoever raises their hand or starts talking, and I think that was just you, Nick.
Okay. Well, I led with my chin there. Listen, COVID is the threat, and COVID is the opportunity. COVID is a threat because of the inevitable distraction that it is causing as this new virus panics governments, puts huge pressure on their economies and their healthcare systems, and leads to focus away from other major infectious diseases. We know that much is evident. But COVID is also the opportunity to say we should be talking about global health security. We should have better surveillance systems. We do need to devote more resources in every nation towards tackling these major diseases, and to ensure that we are in a position to deal with them in future. We do need to invest more in R&D and in ensuring that we have effective community healthcare systems so that we can diagnose and treat these diseases. So COVID is the risk, COVID is the threat, and COVID is also the opportunity to raise the profile of the need to tackle these diseases. And that's the positive way in which we should look at this terrible crisis.
That sounds great. I hope parliamentarians can operationalize that, because that's a lot of information, and I realize that most parliamentarians are or should be in crisis mode right now, since we're not at all out of the woods in terms of the pandemic. Martina, Susan, Adiba, from your points of view?
Sure. So from my point of view, certainly COVID is a threat, but I think from the maternal and child health perspective, I really see that false perception that pediatric HIV and adolescent HIV is something that is solved as a major threat. And that's something that pre-existed COVID. And I really hope that COVID can help us not just realize that we're not done with all of that yet, but also that we have a number of opportunities to do things differently and to really re-energize the work that we need to do on the ground and be able to catch up and, as we say, build back better. In particular, in the R&D space, I think, as I mentioned in my presentation, there's been a tremendous amount of collaboration and leadership and partnership that has occurred over the last 8 months. And I think that that's something we need to learn from, and that's something that we need to replicate in other areas like pediatric and adolescent HIV, because we need that level of engagement and commitment to join forces and for a common goal. And that's something we can't lose and we need to build on. So I really think COVID-19 in that sense is a great opportunity.
Great, thank you.
Thank you, Martina.
Yes.
Adiba, any comments or thoughts on the question about threats? And
yeah, so I think the threat is similar all around the world that COVID has posed us. But in terms of opportunities, I think what COVID has also taught us is how to work more collaboratively, and that certainly should continue, whether it's in R&D or in service delivery, and also the use of technology. I think certainly in the other hat that I wear, which is medical education, we had to quickly pivot to e-learning and did something that was in the planning for over a year, instead over a month. So the expansive use of technology in delivering services is also something that we need to keep improving on, and not just for HIV or COVID, but for all diseases. So I think those are the lessons learned from the COVID pandemic that we should bring forward into the health system in general.
And I would say that one of the big threats right now that we face in HIV vaccine research is a cut in funding, and that particularly with attention towards COVID, that there might be a diversion of funding away from HIV vaccines. And so we really need to be sure that we don't, that we address that threat and that we keep funding at least level, if not improving over time. I think one of the real advantages is a collective impact approach that's being tried by a number of different places in ending the epidemic and addressing the 90-90-90 goals, and that parliamentarians can get involved in both local and national efforts to bring together multiple sectors of society to work towards this common goal of ending the HIV epidemic, and that HIV vaccine research is one component of that, and they can support HIV vaccine research because that is ultimately, I believe, the way that we will ultimately end the epidemic. That we need treatment, we need prevention, but an HIV vaccine is going to be a critical key component to ending the epidemic.
Thank you, Susan. As we know, we have discussed a lot as well about the stigma and discrimination and how it affects accessing services. For that, we would like as well to ask people to check on the Heart of Stigma campaign by the International AIDS Society and let us know how they're interacting with it as well. I currently give the floor to Jeff for the final closing remarks.
Great. Well, thank you, Julian, and thank you so much to all of the panelists for joining this International AIDS Society sponsored session here at the Unite Global Summit. Thank you for everyone joining online. It, of course, and others have said, this would have been wonderful to meet all of us in Lisbon. I'm sure we will meet again soon. We have a lot to do in the meanwhile, not just COVID-19, but as we heard, keeping the focus on HIV, keeping the focus on TB, on maternal health, on child health, keeping the systems, health, social, and otherwise, people-centered. So I'd like to thank Unite for allowing IAS to have this session, and IAS for inviting me to chair alongside Julian. Our next session is going to start in just about 4 or 5 minutes. It's the closing session for the day. It's called the Bird's Eye View on the Continuum of Care. So don't hang up, and we'll see you in just a few minutes for the next session. Thank you again.
All right. Can everyone hear me? Thank you so much for this amazing panel, and thank you again to the International AIDS Society for being our partners in organizing this session. I think the key highlight is the calling for political leadership to not forget about the other infectious diseases that are causing devastation to millions around the world today. So we will take a short break now, as Jeff said, to welcome our closing session panelists. So we will just take about 3 minutes, and we will come back at 3:30 Lisbon, London time. So thank you, and see you shortly.